Does anyone have any questions on any of the last few sessions we've had together? It's all been pretty straightforward. Okay. Well, tonight is one of my favorite topics. I think there's still so much we don't know, um, and the research is a little bit mixed. Um, but when I speak about things in relationship to voice production and the pelvic floor, it's all there isn't really any research that, well, there's one study on singing um, that I put in your Google Drive, and I think it was a pilot study done with musical theater students, and their hypothesis was that the pelvic floor would move superiorly during singing, as it does during forced exhalation and normal phonation, or just exhalation in, um, I guess not necessarily tidal breathing, but more heavy breathing. Um, but the findings of this pilot study was that they actually eccentrically lengthened the pelvic floor as it happens on inhalation, and then they kept it there during singing. But also maybe even more of a strain mechanism. Um, so, and I think that, well, our data is still being analyzed for the pilot study I did in Austria. But it'll be really interesting to see what our findings are, because in all of the forced exhalation data, even the subjects that had some pelvic floor dysfunction showed a reversal of that strain mechanism on forced exhalation tasks. So it seems like that is really the way the pelvic floor and the transversus are designed because of the pressure generation. Not that you can't have pressure generation with strain. Obviously, that's a big part of the strain mechanism, is to have that pressure generation. But my concern is if there are, especially if you have singing patients who are using that strain mechanism for support of the voice, it can lead to pelvic floor dysfunction down the road. And I mean, it's definitely a way of generating pressure, but I don't think that's the way we want to have our patients utilize the pelvic floor. So I know that the anatomy works this way. When I'm teaching you today, this is actually true. But as far as like singing and phonation, phonation hasn't really been looked at yet. So my hypothesis is that the pelvic floor moves up and co-contracts with the transversus abdominis during phonation. But I can't say that that is, proven to the nth degree, and there's no room for debate. That's my disclaimer. But everything else I'm teaching you is pretty much right on the money. So, without further hesitation, and that study I put in the drive so that you can read it, and then also a paper that I wrote that's just a lit review, which I think is interesting because it really shows that in the singing world, there's a very different understanding or different myths that have passed on about support and about the way our body works, and it's not really based in science. And so that's why my focus in research has been, let's really base this in anatomy and physiology and what we understand with the body and how it works, and I'll share the data. Hopefully this summer it will be completed. All right, so glottis to pelvic floor. So I'm going to touch on breathing. We know is, pretty straightforward. Phonation, a little fuzzy. Pressure system, we definitely know. So all right. Okay, so the glottis obviously is the vocal folds and the space between them. And the pelvic floor have a relationship in so many ways, but just physiologically, there are fascial and muscular connections, neural control similarities, and regulation of pressure. So this, I love this diagram because it never ever appears anywhere in textbooks, especially with the idea of pelvic floor even being part of the picture in breathing, in generating intra-abdominal pressure, and even for voice production or phonation. So, so this is a huge step forward in our understanding of and inclusion of the pelvic floor. So basically the glottis, and I know I've said this before, but the glottis is the top of the pressure system and the pelvic floor is the bottom of the pressure system. And in between the thoracic cavity and the abdominal cavity, the diaphragm, which is the primary inspiratory muscle, acts as assists in pressure, in adjustments, and in regulation between the thoracic cavity and the abdominal cavity, and also assists in phonation. So lots of things. That the glottis and the pelvic floor have identical hormone receptors was just really mind-blowing to me when I first found out. So an important thing to know that the changes in the glottis can impact the pelvic floor from a hormonal point of view, from a functional point of view, and we'll talk about this a little bit later, but just have that kind of on your radar. So I had to include this because I think sometimes the anatomy is rushed through in school, and we don't think about it and touch it much, and especially as clinicians, we end up just seeing the vocal folds from the superior view, and we don't always remember that, this is a big part of our upper airway, and so I just included it. And obviously the vocal folds are behind the thyroid notch anteriorly and go, back to the vocal processes in a V. But it's also connected to the respiratory system, and we'll talk about that more. So here's my favorite little picture of the glottis. So it's obviously the control mechanism for us for allowing air in and out of our bodies. And obviously the open glottis allows the air into the lungs, and a closed glottis acts as a valve to control pressure, intrathoracic pressure. It resists subglottic pressure, which the definition of that is glottal resistance. And it interacts a lot with the diaphragm for phonation purposes and also for pressure regulation. And I think, as we talked about in our paralysis, that the innervation for the vocal folds and all of the intrinsic laryngeal nerves comes from the vagus branch, and is divided into superior and recurrent laryngeal nerves. This is obviously a review, I know, but I just want to have that sort of as a complete idea from glottis to pelvic floor. So I thought this was a really cool diagram because a lot of times when we think about our skeleton, we don't necessarily think about where the trachea is and how far it goes, and where the bronchioles are and the lungs and all of that. So it's just kind of nice to see this really organized schema of larynx, trachea, and then you can see here the body of the sternum, the manubrium, and then the xiphoid process. So manubrium body and xiphoid process. And I don't think I have anything more to say about that. Also, really interesting that the ribs are the most flexible bones in the body. How many knew that little? No, I didn't really know that either. So that is really helpful for breathing, right? Because we need the rib cage to move as the lungs expand and deflate. And they actually have multiple joints. So there are joints here, so at the attachment of the sternum, here and out here. And that was also something that I never even knew. How about anyone else? No. So our rib cage is pretty spectacular and very dynamic and very movable, thanks to those little ribs, or the little joints. And you can actually see those here, and all the way down to here. And the part of the rib that connects to the spine is characterized by the head, neck, and tubercle. All right. This also I just added because it was a really nice way of seeing larynx to diaphragm, which is not something that we see very often either. So you've got this really great complex system, and this is what regulates the pressure in the thoracic cavity between the glottis and the diaphragm. So I know we've talked a little bit about the diaphragm with the reflux, but I'm going to go into a little bit more depth here. So we know it's our primary muscle of inspiration, and we know it separates the chest cavity from the abdomen, dividing it basically in upper and lower halves. I've talked about its connection to the xiphoid process, the bottom 6 ribs, and the spinal processes of the spine, and the vertebral discs. And let's see, it's involved in other non-primary respiratory functions, such as the maintenance of correct posture and lumbar and sacroiliac movement. And it extends along the bottom of the rib cage in the back, so down to the 10th rib in the back. Kind of shaped like a boomerang with a flat tendon at its center. And the tendon actually is a functional tendon. It makes a difference in its function as well. And it's unique in that it has voluntary and involuntary control, neuromuscular control. So there are 2 sections of the diaphragm that can work independently. One is more a breathing function, and the other is, can anyone guess? You can unmute yourself.
I was just going to say pooping.
Pooping. Well, other end, swallowing. But it's not that it doesn't. It definitely plays a role in pressure adaptation for sure for pooping, but it's not the primary pooper. The diaphragm is assisted by the accessory muscles in the neck and the external intercostals for inspiration. So it's the primary muscle, but it has some helpers up in the accessory muscles and the external intercostals. And then the primary muscles of exhalation include the pelvic floor, the transversus abdominis, and internal obliques and internal intercostals. So those are the muscles that we use for during inhalation and exhalation. And then just kind of, this is a cool little diagram where you actually can see, you don't see the lungs, but the heart rests right on top of the diaphragm. And imagine that the lungs are also right on top of the diaphragm. And it's works with breathing, as we talked about, swallowing and vocalization, and aligns with the vagus nerve, which provides the parasympathetic supply for all of the organs of the chest and abdomen. So again, we've got some consistent innervation all the way down to the diaphragm. And just, I like this view of its relationship to all the other organs in the body. So you can see the stomach, the liver, heart, lungs, and the heart and lungs, you know, are right on top of the diaphragm. And then you can see the digestive tract as well, and here's your pelvic floor. Actually, I'm going to go back for a second because I had some notes here. The organs located below the diaphragm don't move that much when you breathe lightly. They only displace down and out when you have a deep and full breath. The dome of the diaphragm is higher on the right side than the left. On the right side, the liver displaces the diaphragm upward a little bit, so that's why it's higher. And on the left side, the stomach, which is smaller and hollow, is located below the diaphragm. And the back, tucked under the ribs and contacting the diaphragm, is the spleen. So a lot of vital organs here, and both kidneys are also located just below the diaphragm in the back. And so during the initial phase of inhalation, they're merely compressed like a sponge. And at this moment, the elastic resistance of the organs helps to tone the diaphragm. And the diaphragm actually also helps to tone the organs through the movement. So they have this really cool symbiotic relationship. Again, never learned any of this in school. So I'm totally geeking out on this. During further inhalation, they move downward and escape sideways too. So if you imagine that you've got the diaphragm on the top and my pelvic floor is actually at the bottom. When I contract, you can see how if the ball is the abdominal cavity, it displaces forward and slightly sideways. And that's because we've got a spine behind it, so it can't go anywhere else but forward. So just having that understanding of why things need to move down and out. There's actually a physiologic reason for that. So the location, so I did say that, the location of the spine limits the backward movement, but the spine does contribute to breathing by going slightly into extension during inhalation. And did I ever show you the respiration total video? No, okay. I'll throw that on the Google Drive. It's a really cool video on total respiration and how they actually have the different osteopathic diaphragms. So you've got not only the pelvic floor, but then and the inspiratory diaphragm, but then I think they have the floor of the mouth and the soft palate and the cranial diaphragm. So it's kind of cool to see how there is just a relationship between everything in the body during inhalation, and it's all, you know, down on inhalation and up on exhalation. So that part is just really a consistent thing in the research, and in just the descriptions of the functions of the body. So other interesting point, the diaphragm also intervenes to clean up the upper airways through coughing. It facilitates the evacuation of the intestines. So you weren't incorrect, Claire. It does assist, and it promotes the redistribution of the blood in the body. So all of these things are super cool, and that's why we need to really love our diaphragm. So I'm sorry I didn't remember that in my my notes, that it assists in evacuation. So you're right on. All right. So on to the lungs. Obviously we have two lungs, and they do sit right on top of the right and left hemispheres of the diaphragm around the heart. The central tendon of the diaphragm blends with the pericardium, so that's the lining of the heart. And then during inhalation, the heart and lungs have a little elevator ride, and upward during expiration. So imagine your heart and lungs having a little nice ride every time we breathe. Again, not information that I was ever taught. So I just love this. And maybe, Claire, while you have a little extra restriction in your movement, as you get more pregnant, you might notice things like that a little more, because you have a little extra pressure and resistance there. Anyway, you can share with us. So obviously the lungs are located inside the rib cage. They follow the movement of the diaphragm, and the rib cage, due to the vacuum that exists between the rib cage and the lungs, this negative pressure, the lung is encased in a thin membranous sac called the visceral pleura. And they have an interaction with pressure between the rib cage and the lungs. And they slide on top of around each other, so that there's this nice, really fluid, easy movement between the two. And there aren't any ligaments or muscles directly attaching the lung to the rib cage. It's just through that pleural membrane and the interaction of pressure, negative pressure. So obviously it would damage the lung if we had attachments of muscles or ligaments to it, and limit the amount of movement in the lung. And let's see, what else did I want to say? They're responsible for aerating the blood. Ventilation is the process of bringing air into the lungs, and respiration is the process of gas exchange in the lungs. So ventilation versus respiration. And then during the process of respiration, oxygen passes into the bloodstream while carbon dioxide is moved out. I think we all learned that a long time ago, but it's a nice thing to remember. Review. The air needs to be 100% humidified too. And so that's part of this process. All right, so the diaphragm and the lungs. This is an Eric Franklin beautiful illustration of how the lungs move with the diaphragm. So the diaphragm contracts, the filaments slide together and move down into the body and flatten out a little bit. And so that downward contraction pulls on the pleural membrane outward, making the lungs expand. And that negative pressure is what draws the air in. And the lungs then slide into that available space in the rib cage. So, and then the muscular attachment of the diaphragm assists in expanding the lower 6 ribs so that there is more movement and more room for the lungs. So I think that's kind of a common misconception that that with breathing it's like filling up with air like a balloon, or the lungs really are expanded by the vacuum that surrounds them between and the movement of the diaphragm that causes that vacuum. So just another thing to remember, that it's not like we're not filling it up with air the way we would think blowing up a balloon happens. So then also diaphragm slowly restores to the dome position on exhalation, aiding airflow movement up through the glottis and assisting with phonation that way. So, so just that movement assists in moving air as well. And that's why it makes so much sense to me that the diaphragm and the pelvic floor need to be moving this way to assist the movement of airflow through the glottis and out. So hopefully that's what my research shows, but who knows. Okay. Any questions so far? I'm kind of blowing by some pretty pertinent information, but all good? Okay. So the relationship between the diaphragm and the pelvic floor, again, beautiful depiction. Where do we ever see this? Like, I feel like every textbook that I've ever looked at that talks about respiration stops at the diaphragm. So this is really cool. I'm not exactly sure. Obviously, this muscle is the psoas that we will not talk about tonight, but we can talk about if anyone's interested. So here you have your diaphragm and the pelvic floor, and what's missing, obviously, is the abdominal wall. So the diaphragm and the pelvic floor work in parallel, phase-locked movement with one another. So they are just opposite in function, and I know I've said this before. So the diaphragm contracts on inspiration, the pelvic floor contracts on exhalation. And a change in the diaphragm results in a symmetric change in the pelvic floor. And even though the pelvic floor isn't the active contractor, it's still eccentrically contracting and increasing in tone by about 20%. So it's not relaxed. It's just not the active contractor. And then the roles reverse. So the diaphragm is eccentrically contracting during expiration. And this is important for posture, trunk stability, and forced exhalation and phonation. And when we add the abdominal wall, which we'll do in a little bit, the interactions between diaphragm, abdominal wall, and pelvic floor are consistent and also important for stabilization of the trunk and movement. But breathing is always the most important function for everything. So no matter what you're working on, breathing has to happen as the primary experience. So there is research that shows the interaction in breathing between the diaphragm and pelvic floor. So again, I can say that with certainty. So here's one of my favorite muscles, the transversus abdominis. This is now without any other muscles, no diaphragm. But if you remember where the diaphragm attaches, there's the xiphoid process, the bottom 6 ribs. Hey, look at that. The transverse abdominis attaches there as well. Also here at the iliacus of the pelvis, the iliacus muscle is on the inside of the iliac crest here on both sides. And then my picture got a little cut off, but right here, what we can't see is the pubic symphysis. So the both sides of the transversus attached to the joint at the pubis, right there, and also to the spine and back. So the relationship between the diaphragm and the transversus is important because this muscle is the antagonist to the diaphragm, which makes sense because the diaphragm is active contractor during inhalation, and pelvic floor and transversus are active contractors during exhalation. And you can see how that the TA, the transversus, I either call it TA or tranny, so if you hear me slipping into those instead of the full name, that's what I'm meaning. Same muscle. This passively assists in rib expansion during inhalation and also helps kind of slow the restoration of the doming of the diaphragm, which I think helps keep the ribs from collapsing. So an important function for phonation as well. And it is the connection between the diaphragm and the pelvis through its muscular connections. It also assists in stability during exhalation. So the transversus is capable of many, many, many things all at once. It's a very good multitasker. So if you read any of the physiology literature, the transversus is the main trunk stabilizer, but it's also one of the main exhalatory muscles, and it also assists in movement. So you've got all three functions of the abdominal wall, which are breathing, stability, and movement, that are happening. And so everything has to still happen as far as breathing is concerned with stability and movement. So it's very, very, very sophisticated. And then I think that was all. But lots of really great functions. So the pelvic floor and the abdominal wall. As I said earlier, the pelvic floor is the valve of the pressure system at the bottom of the abdominal cavity, and like the glottis, resists and regulates pressure. The pelvic floor by itself, not really a big deal as far as pressure generation, but in combination with the transverse abdominis really is a necessary piece to that. It's just like we can't hold our breath without closing our vocal folds. So really important, and actually some of the research out there used EMG probes to measure the contraction of the pelvic floor and the TA during forced exhalation and maneuvers like Valsalva. And they did see a change in pressure in the pelvic floor as well as the TA. So it is happening. It's just, if you just kegled and forgot about the transversus abdominis, you're not really going to have much pressure generation for intra-abdominal pressure. So that's an important thing too, because some people think pelvic floor contraction is just Kegel, but that's not the case. And we'll talk more about that. The pelvic floor works with the transversus, but also with the internal oblique and internal intercostals for exhalation, but mostly transversus abdominis and pelvic floor for intra-abdominal pressure increasing. And then that increased pressure generation is what we use for our postural stability, stability of the trunk, and also for reflexive forced exhalation like coughing, sneezing, nose blowing, laughing, and then also with phonation. So it all kind of makes sense, doesn't it? Like if these things happen naturally, like the nose blowing, sneezing, laughing, coughing, those all work in that manner, then it makes the most sense that it would work the same way in phonation, which is forced exhalation, right? Okay, good. And so here's just a really clean look at diaphragm, abdominal wall, pelvic floor. So you can see here on the left, inhalation, diaphragm moves down, abdominal wall moves out, pelvic floor moves down. And on exhalation, just the opposite. Pelvic floor moves up, abdominal wall moves in, diaphragm restores caudally, or superiorly. Just kidding. So everyone kind of clear on those concepts? Awesome. Again, Eric Franklin, illustrator here. Another Eric Franklin. Beautiful picture of the pelvis looking inside, and you can see there the pelvic floor. So why am I so completely focused on the pelvic floor? Well, training it is essential for optimal function, and coordinating phonation with pelvic floor and transversus is, in the research, a necessary thing. It has to be trained for these kind of functions, because the body does the reflexive behaviors automatically, but we don't necessarily do phonation or speech or singing utilizing pelvic floor and transversus. So it does have to be trained. And that's why I think that sometimes when we look at the research, we're looking without training these subjects. So if they have patterns that are already established, or that a teacher had taught them, then that's what's going to show up in their behavior. Even if it's not the correct behavior. And we've seen that in all of our patients, right? Like with the muscle tension patterns that people get really good at, even though it's not functionally correct or helpful. So let me introduce you to the pelvic floor. It is a selective supporter. So it holds in our abdominal organs. It allows for pelvic movement during walking, sitting, and any other movement. But from phonation, it's part of the abdominal wall musculature that we use for intra-abdominal pressure. And why is that important? Because intra-abdominal pressure, through the regulation of the diaphragm, becomes intrathoracic pressure. Through the regulation of the diaphragm, becomes subglottic pressure, supraglottic pressure, and then out to S, atmospheric pressure. So it's really about pressure regulation and manipulation. So as far as this, it's also a selective releaser. So Claire, you'll be discovering that. It's important in elimination of bowel and bladder, but also for birthing and menses. We don't want to mess too much with the pelvic floor. It shouldn't be constantly or rigidly held. And I think when I look at patients with pelvic floor dysfunction, it's usually that is the problem, that they're holding the pelvic floor musculature tense and that they don't relax it well. Even though the muscles, because they're an active supporter, never relax. Like we can relax other muscles. It always needs to be kind of awake and on and responding to pressure changes in the body. But you can release it from extreme tension, and you can feel that if you inhale, exhale all of your air, and then just let go, and it does release. You feel a little bit of a clunk, and that's something that you can practice, and we can practice this together in a little bit. It also shortens, so that the filaments of the muscles, just like any other muscle fiber, will slide together on contraction and will slide apart on eccentric contraction. So active contraction slide together, eccentric contraction slide apart. And that's a really nice image too, to just feel, instead of just thinking the muscle bunches up on contraction and relaxes on relaxation. There's always a little bit of activeness in the muscle in a really helpful and healthy way. So, and we're going to go through the specific muscles in a little bit. But one of the things I want to kind of mention, and I think this is an important thing, especially for our patients who have a lot of muscle tension, is this little complex of muscles. This is the rectus sling. And when we have patients with the head forward posture or head up posture, or utilize kind of upper ab compression in for voice production, they are actually compressing things in a way that are not supposed to be compressed for pressure generation in the body. The rectus sling is primarily a flexor muscle and an extender muscle. So, you know, it's called the six-pack ab musculature, and you can see each of these muscles is in its own fascial compartment. So if you cut open the ab, you'd see like little circles of muscle in different segments. So it actually allows more segmental movement in the abdominal area, which is great. But its contraction also can put pressure on the stomach, exacerbating reflux. It can cause tension that goes all the way up to the floor of the mouth, which is problematic for voice production. And, you know, it's just kind of in the middle of everything. And often the focus, from an exercise point of view, everyone wants to do crunches and have their six-pack abs. But if there's too much tension or bracing in this area, it negatively impacts the voice. This is another reason that I focus so much on pelvic floor and the deep abdominal musculature, because there isn't that pressure on the organs that occurs with the transverse, with the rectus abdominis. So,
Kate,
and,
I actually, oh,
yeah,
sorry, can you hear me?
I can.
Oh, sorry. I was going to say, I actually have noticed that in myself. I've been working out a lot and doing a lot of ab workouts, and I think I've developed muscle tension in the floor of my mouth from it.
Oh no.
Because I don't think that I'm breathing during some of the exercises a lot. And so I've started to notice a lot of tension, like right at the highlight and underneath the floor of my mouth, mostly on this side. So I've been trying to do like a lot of manual release to myself, but I can feel it. Like I'm like, when I'm doing my exercises, I have to tell myself to breathe, because otherwise I'm like holding my breath a lot. And then I start to feel all this muscle tension under here.
Right. Wow. Well, that's I'm glad that you noticed it, but just a reminder to yourself and to your patients that if they're doing exercises, that can definitely have an impact on the voice. And so breathing has to remain the first priority on top of everything else that we do. So if we're doing crunches, we have to still be able to breathe so that we're not gripping or holding. And you can kind of do like a little shake with your arms to make sure you're still breathing when you're doing your ab workouts. But one of the things that I think is really cool about this is if you learn to use this sling well, it really does help aid in that flexion and extension of that sling. And so you can really feel, if you think just a little forward when you're doing a crunch, and then start with the geniohyoid, and then sternohyoid, and then each compartment of the rectus, and also the bottom part of this sling is a pelvic floor muscle, the pubococcygeus muscle. So if you think of that moving up this way, it actually really helps your flexion in a crunch and the extension. And you can kind of release it and practice this with cat-cow to do a little more extension, a little more flexion in a more segmental manner while maintaining breathing. So that is a safer, more efficient way of doing abdominal muscle exercises. There are also other exercises that you can do to strengthen the abs other than the sit-ups. So if you're interested, I can share those with you.
Yeah, definitely.
I think I know, I told you this, but I'm in level 2 training for the Franklin method, 2 out of 3. And we just covered all of this in the abdominal wall in this whole series. And it was like a major aha for me, because I used to like doing sit-ups too. But when we did the sit-ups in a really efficient and slow manner, you get a lot more bang for your buck and don't have to do quite as many if you're just doing a limited range of motion versus the whole sling interacting, which is pretty cool. But I'm glad also that you can see how that's all, like, these are all part of the voice, you know, the floor of the mouth attaching to the hyoid, the sternohyoid, you know, right around the larynx to the sternum. And then, yeah, just also the whole caving in of the upper abs is a big sign that your patients are hyper-recruiters of the rectus. I had a really interesting patient on Tuesday. I saw this person with a physical therapist. He reached out to me because of my research, and he was having trouble with his voice. So we actually worked together with him and used transabdominal ultrasound to actually watch his breathing and the movement of his pelvic floor. And on his skin, in his upper abdominal area, and then you can't see me, so kind of like right here, there was a line on, like, just a crease kind of in his skin from hyper contracting his rectus. So he kind of created this permanent line from that. And so that's also something to just be aware of. That's a sign of hyper recruitment of the rectus. And why would this also be potentially problematic for voice production? Any ideas? So you can see how high on the ribs, so this is the 5th rib that the muscle attaches. If this is really tight, is that going to impact breathing? Yeah. So it can limit breathing. It can also create sort of an overall bracing, which makes movement and flexibility much, much more difficult as well. So just for an experience of that, go ahead and just grip your rectus. And now take a big breath without letting go of the rectus. So I feel major limitations in my breathing when that's that tight. Anyone else feel that?
Yeah, and it has to be a higher, it's like a higher breath. You're
Exactly. It
up here.
forces you to go elsewhere because you can't access the things you want to access, right? So I know this isn't part of the pelvic floor, but this is such an important bit of information. And Lauren, I think, shared her experience of that. Yeah, and you don't even realize that it's happening until, like, oh crap, I'm tight here. So I would use my little Lilo on your tongue base. Get in there and release with vibration, quite a bit of vibration, to help if you have one of these. Quite helpful. So let me just check them, make sure that I got everything. Yeah, so just be aware that when you talk about abs, there are different abs and they have different roles and functions. So the superficial ab, mostly flexor and extender. The internal and external obliques, also flexors primarily. They can be side flexion, lateral flexion, and rotators, but they're not really the big pressure generators. They may assist the internal oblique because of its approximation to the transversus abdominis, assists in that, but it's not a big player. So just for visualization purposes, you've got this rectus sling, and then underneath the rectus sling, and the rectus also is housed in its own fascia called the rectus fascia. So that's also, it kind of moves in its own little package and slides along the other fascia of the abdominal muscles. They all kind of slide around each other, which is great for movement. So you've got this rectus abdominis, then you have the external obliques that kind of run this way, like you're putting hands in a big hoodie pocket, and then the internal obliques that run this way, and together they kind of overlap and mesh between the internal and external obliques. And then below that is the the transversus, abdominis, the deep abdominal muscle that we want to focus on for support in breathing. It's known as more of the breathing muscle, and its partner, the pelvic floor. So hopefully this is novel information for you that's helpful, and again, beautiful illustration by Eric Franklin. So here we are at the pelvis. Just an orientation, because we don't really talk about this much in speech path. So we have, in fact, we can just sort of feel our pelvis as we do this. So we've got two pelvic halves, the iliac crust to the pubic bone, the sacrum in back here, the ischial tuberosities, the sit bones, and the coccyx at the back, at the bottom of the sacrum, and the bones between the pubic symphysis or pubic bones and the hip joint is called the pubic rami, but you don't need to really remember that. But that's what houses our pelvic floor, and it's really important for movement, and it's a flexible, counter-rotating kind of bony structure. So, so we can walk and move freely. It's great. Let's see, what else did I say about that? I guess that's it. So did we all feel pretty clear on that? I know I went through it pretty quickly. Okay. And here's just the pelvis from the side. So the reason these are important borders is that the pelvic floor attaches front to back, pubic symphysis to coccyx, and side to side, ischial tuberosities. So you've got this little trampoline of muscle, and it's attachment points. So I think that's helpful to know. And when you describe it to patients, if you ever decide to share this information with patients, for kiddos, I say it's what you sit on a bicycle seat, so that you don't have to go into the anatomy and physiology much. And you can feel it kind of moving up like a trampoline. I mean, you can be really creative with kids, and they have really great imagery skills. So you can let them maybe create their own image, like a fountain moving up and in, those kind of things. But this is just helpful to have an orientation. And then I'm just adding a little bit of information, kind of, so you can see that in this pelvic half, you've got muscles of the pelvic floor underneath the sit bone. You've got your glute med on the back, so you're right in the back wall of the pelvis. And then these become more of the active muscles around the pelvic floor and its function. So we've got a little bit of internal oblique and transversus abdominis, which we talked about, kind of work together a little bit. The external obturator and the latissimus all kind of attach a little bit to the pelvis. So just kind of a neat idea that, wow, it is pretty integrated to the muscles in the back, to the muscles in the abs. So quite sophisticated in itself as well. So I added this again because now we're going to talk about the muscles a little bit. So here again is your sacrum, and the coccyx is kind of displayed here, even though it kind of moves more down like this. You've got your glutes on the outside, and then if you take your hands and just, you can imagine your glute max and glute med, and then move down and you have your piriformis muscle, and then move down, you have the coccygeus muscle, and now we're in the pelvic floor musculature. So coccygeus, and then you have the internal obturator makes the side wall of the pelvic floor, and then you have the levator ani, which is 3 muscles, which is the iliococcygeus, pubococcygeus, and puborectalis. So I kind of think about a little iliococcygeus, pubococcygeus, puborectalis. And those are the active muscles of the pelvic diaphragm. I never forget it now that I have my little wrap, so maybe it'll help you. But then you can see the joint here of the pubic symphysis. It is actually a joint. All right, so now we're going to just look specifically, because I think this is sometimes hard to tell which is which. So here we have your piriformis, and above that would be the glutes, the glute max and glute med on each side. Here's the sacrum, there's the bottom of the spine, and there's the coccyx. So then we have the next muscle, which is the coccygeus muscle. And it's pretty much attached to the coccyx. So it's named well. So that is actually, the piriformis isn't really a pelvic floor muscle, but its approximation is worthy of sharing that information, because most of us are familiar with our piriformis for one reason or another, usually because it's being cranky. So then you have the internal obturator. So this is the side wall, and then you can see the coccygeus here too. So this is the side wall. I didn't light this one up too, but this is also the internal obturator. Sometimes when the pelvic floor is tight, this muscle is the culprit, and unfortunately, it is close to the pudendal nerve, which is the innervator of the muscles in the pelvic floor, and it can be super painful. So if you have patients who have pelvic floor dysfunction, that pelvic pain can be a big deal. So and then we have the iliococcygeus, and it's not really well named because it's not attached to the iliac crest of the pelvis, but it is attached to the coccygeus, or the coccyx. So That's one of the levator ani muscles, the iliococcygeus muscle. So it's quite big. And then you have the next levator ani, the pubococcygeus. So coccyx to pubic bone, really nicely well named. And then if you look at its pair, because this is also the pubococcygeus, does it kind of remind you of the glottis? If you use your imagination, it sort of looks like a V, right? I don't think that's an accident. From one valve to another. And then the puborectalis. And this is the muscle that you don't want to weaken, because then you have emergencies of the pooping kind. So you want your puborectalis to be nice and strong. So that's what, when people think of the pelvic floor, that's what we see when we look inside the pelvis. So if you see inside my pelvis here, that's what we're looking at. So normally this is the orientation. So these are the internal obturators making up that side wall. And here you have the urogenital triangle. So you've got your urethra, vaginal area, and your clitoris here, and then the anal triangle and back. So pretty complex. You can see here too, this is basically the outside version of what we're looking at on the screen. So, did I go through that too quickly? No? Okay, great. All right, now we need our piece of paper. Does everyone have one? Okay. So, we're going to take the 8.5 by 11 piece of paper, and we're going to pretend we're making a paper airplane. So we're going to fold the top into a point. And then we're going to do the same thing on the other side. Okay, so everyone should have a diamond-shaped piece of paper. Beautiful. Okay, so we're going to take a pencil or pen, and I want you to just label, let's see, I'm just going to put a pencil. On the top, I want you to put a P for pubic bone. And on the bottom, we're going to put either C or T for coccyx or tailbone. And can anyone guess what the sides might be? The ischial or ischial tuberosities or sit bones. So those can be S's. Okay, so P on the top, C on the bottom, and S for sit bones. Now, if you have a colored pencil or marker, we're going to take going up from the T to the S in one line. And then the same thing on the other side. So the T to the coccyx, C to the sit bone. Okay. So I don't know if you can see mine. So it looks like a big V. Okay, how are we doing so far? And that is the coccygeus muscle. So you can write on there coccygeus, or you can just make a mental note. And now we're going to take another color, and we're going to draw kind of a parallel V to the coccygeus, and that's the iliococcygeus. So a little ways up, still related to the coccyx. I'm doing this at my piano, so I don't have a whole lot of space to draw. All right. So this is the iliococcygeus. Now we're going to take another colored pencil, and we're going to start kind of right above the V of the iliococcygeus. And we're going to make kind of an arc between that V of the iliococcygeus and the pubic bone. So and that is the pubococcygeus. So between the pubic bone and the coccygeus. So a little arc on each side. And then from the pubic bone, we're going to do with a different color. We're going to do a little sling. So right in the middle of everything. So like that. So from the pubic bone around, and I'm going to put in here which will make more sense. That's your anal sphincter. Just make the anus and the vaginal and urethral. This is the female pelvis. Okay, so that's the puborectalis. How's everyone's pelvic floor coming along? All right, now if we turn this over, we have 4 little triangles, basically, and that represents the urogenital triangle be underneath the pubic bone. So you can and on the coccyx side triangle is the anal triangle. So if we could put this on like a panty, imagine, that the urogenital triangle is in front, the pelvic floor levator ani is in the middle, and then the anal triangle is in the back. So this is what we actually do see in the real pelvic model. So here's the urogenital triangle and the anal triangle and the pelvic floor. So if we had tape or whatever, we could tape this to our bottom half and basically have our own model of our pelvic floor. I think it's just helpful to kind of understand what the pelvic floor is, because so many people talk about the pelvic floor, but they don't really know what it is, or what muscles are involved, or how it works, or how it orientates in the body. And so you've the triangles, the urogenital triangle, and is mostly our bladder control and our sexual function as females. And the anal triangle is also could be sexual function, also obviously where we remove waste from our body. So that's the superficial pelvic floor. And then the deep bowl of the pelvic floor is the deep pelvic floor. And there's a perineal body in the middle of the deep pelvic floor, the levator, near the levator ani, and that is what lifts. So, so the whole levator ani is the lifter, and the urogenital triangles are the closers or the contractors. And so when you do a Kegel, you're pretty much just doing the close. And some people can just do the vaginal wall as females. You can actually be taught to access that close with the urethral sphincter. Or as women, we can access the pelvic floor close or Kegel with the anal sphincter. So, and with men, they have the anal sphincter, and then they have the perineal body. So they don't have as many choices. But I guess you can also, they have the urethral sphincter as well. But it's a different feel and a different description for men, because the perineal body is basically right above where the ball sacks come from the body. So that's where they're going to be lifting, where that perineal body is on the inside of their pelvic floor. And that's a good kind of understanding as the clinician to kind of know where you need to tell them. And it's kind of, right in the middle of their pelvic floor. So that's another landmark too. But Kegeling is just accessing one part of the pelvic floor. So in order to do a complete pelvic floor contraction, you need to close and lift up toward the bladder base. And I don't think that's well understood. The other thing that I think I want to mention, even though this is not really a hormone class, but we talked about the hormone receptors, the estrogen receptors in particular, that exist both on the tissue of the vocal folds and the pelvic floor. when we age, and none of you have to really worry about, I guess Susan and I are probably the only ones that are in that category of worrying about this, but also the knowledge of this as a young person is really helpful because our hormone levels are depleted as we age, especially estrogen. And one thing that singers in particular like to do is supplement the estrogen as they lose estrogen once they stop ovulating. And um, and this is true for not only the glottis but the pelvic floor. And if you have a patient who has had some kind of hormone receptor positive cancer, they're not allowed to take hormones systemically. However, they can use an intravaginal device called S-string, like estrogen, but S-string, and it's a intravaginal, I should say, not uterine, intravaginal ring that time releases a small dose of estrogen that's not enough to impact the systemic estrogen moving through the body that would be problematic for someone who's had a hormone receptor positive cancer, but it's enough to prevent atrophy of the pelvic floor muscles. So really, really big deal, important to know. Again, this information isn't being shared with women in general, and I don't understand why. But I discovered it in doing my literature review. I was reading several papers talking about atrophy of pelvic floor. I was like, what? And once it gets to a place where it is has atrophied, it's not easily reversible. So if you can preemptively maintain the health and wellness of your pelvic floor hormonally, that's a really good idea. So just know that that's a thing. There are some interesting ways of adding estrogen to the glottis or the vocal fold tissue through inhalation, aspiration, like nebulizing almost. But that's not safe for women who've had any kind of hormonal receptor positive cancers. And women who don't have those risks can take low dose estrogen safely. But one thing to know kind of as a young woman is what is your physiologic baseline of estrogen. I know it varies through your cycle, but kind of know your range now as a young woman so that you know what restoring your estrogen level to physiologic level would be when you go through menopause. Just kind of keep that little piece of data in the back of your mind and know that if you are able to and decide to do HRT, hormone replacement therapy, that you know what is normal for you, because you don't want to take any higher dose of estrogen in your postmenopausal years than you need to. And I know you don't have to think about this for a long time, but just remember, oh yeah, Kate said something about this like a long time ago. So, all right, how's everyone doing? Do we need a stretch or a bio break or anything? Are we good? Okay, all right. I think because we only have 8 minutes left, do you want to just do next week, just continue this topic and do all the practical exercises and things? Yeah, okay. I'll just briefly show you the coordination of glottis and pelvic floor, just so that you have that in your mind going into next week. So they're very symbiotic. So we talk about the release. When I talk about the release remember, it's a general release. It's not a complete release in the pelvic floor. But we release the pelvic floor as we open the vocal folds. So on inhalation. This allows the diaphragm to move its full excursion into the body and have the organs, the abdominal organs, displace forward and out to the side. And then that pelvic floor actually increases in tone and moves away, out of the way of the diaphragm. So that's happening on inhalation. Then exhalation, we close the superficial pelvic floor, we lift the deep pelvic floor, which co-contracts the deep abdominal muscle, or the transversus abdominis, for pressure generation, regulated by the pelvic floor and the diaphragm and the glottis. And the movement of air and through pressure exchange is how we get subglottic pressure and air movement through the vocal folds. So I teach a lot of hand modeling, open glottis, relax pelvic floor, close lift, pelvic floor, phonation. I also do hand models with diaphragm, abdominal wall, pelvic floor too, and I think that's helpful. I think especially we end up seeing a lot of patients who don't breathe well. And having this knowledge is really helpful in teaching our patients how to breathe well. And I still love Lauren's hands on the rib cage, just to feel how the diaphragm influences that. And even if you inhale and then Kegel and lift the pelvic floor, can you feel that there's a reinforcement of that rib expansion? And then if you're a singer, you want that diaphragm to slowly restore to normal, or you go and you run out of air. And I was playing, I could see why people are tempted to do the strain mechanism, that bearing down. And that's really only reserved for birthing. Even when we're pooping, we shouldn't be bearing down. If we're bearing down, we've got a constipation problem, and that can impact the pelvic floor and weaken it in the same way that having chronic tension in the pelvic floor can weaken it. So really imagine if that's how you sang all the time, you'd be experiencing some major changes in your pelvic floor pretty quickly. I think I heard a story of somebody actually losing their bowel and bladder on stage. And that's not a pretty look. So again, up and in, keep everything the way where it's supposed to be. No strain, because also when you're generating that kind of pressure, what's happening at the glottis? Lots of pressure, right? Lots of close, and so that also isn't healthy for the vocal folds. We want some resistance, and entrainment obviously is normal, but increasing that pressure is not normal, and then you start to hyper recruit all sorts of muscles. So this is the anatomical and physiological correct information of the glottis to the pelvic floor.
Hey, can I ask you a quick question?
Of course.
This is kind of related to what we were just talking about with the rib cage, but I have a professional singer that I just evaluated, and he actually just went on tour and is doing like 11 shows in 9 days. And he was asking me for like some tips, and I was assessing his breathing and whatnot. And he did a lot of like clavicular breathing. And so I had told him, like, for some biofeedback, maybe to put like a TheraBand like right at the bottom of the rib cage underneath his shirt, so that he can kind of get that biofeedback for himself while he's singing, just to kind of cue him. Would that be something you would suggest?
Absolutely. Yeah.
Okay.
It's one of my tools in my toolbox that I give to all of my singers. I get them the singing straw, and the resistance band, for that very reason, because sometimes hands on the ribs isn't enough of a translation to what actually is happening, especially if someone isn't very aware physically of themselves. And that's why teaching them to embody this a little bit is really helpful, because then they get it. They get the sense of it. And one of the things that I'm exploring after this session I had on Tuesday is a little mini ultrasound device that you can actually plug into your iPhone and see what's happening in the abdominal wall and pelvic floor and diaphragm. Because when I taught advanced vocal pedagogy at DU at the University of Denver, I took all of my students to my friend who's a pelvic floor specialist, physical therapist, and she did trans-abdominal ultrasound on all the students. And it was interesting because there were some who really contracted their pelvic floor well. And then there were some who thought they were contracting their pelvic floor, but they were actually engaging their external obliques or even their rectus. So having that visual is so helpful. And I think once you see it and once you experience that full pelvic floor contraction, superficial and deep, you really get it. Then it just is like really imprinted on you that, oh, that's what it is. That's what it feels like. That's what I'm doing. Or, oops, I thought I was doing that, but I'm not doing it. And I don't know what our scope of practice is. There's probably no conversation about that, but really be interesting to get just trained as a side training for myself. But anyway, that was a little extra information. But it isn't really something that we know anything about. No one ever talks to us about this. It's such an important part of our body. And really, no one talks a whole lot about the diaphragm either. And I listed all of the functions of the diaphragm, which they're just so many. So having that knowledge, that embodiment, that coordination, excuse me, is really, really important. So, any other questions? I know this was a lot of information. Thank you all so much for being here. We'll continue with the practical aspect of this next week. I'll do a little reminder of things, but it'll mostly be practical, tools that we can use to help our patients and ourselves embody this breathing in coordination. Have a great night, everybody.
Thank you,
Thank
Kate.
you.
You too.